I'm going to be speaking about Ebola. And my experience with Ebola was 13 years ago. So it's been 13 years since I've really thought very much about Ebola, but it was very interesting to sort of think back and prepare the slides and look back at the outbreak that we worked on in Uganda in 2000, 2001. I do think it has some relevance to what's going on now in West Africa. So I'm happy to have a chance to present. I'd also like to thank Dr. John. I think Dr. John gave us a really good overview of global health security. Ebola is one part of that, but as Dr. John pointed out, there are many parts to that. And there's lessons we learn from all of these experiences that sort of help us pull everything together for the next outbreak, the next epidemic. So let me go ahead and get started. I would like to say that our response in northern Uganda was actually a collaborative response that involved the Ministry of Health in Uganda. There were local health officials. It was largely led by the World Health Organization. CDC provided laboratory and epidemiologic support. And MSF, Doctors Without Borders, was there providing direct medical care as well. So I'm going to go quickly just through some introductory information about Ebola. It is from the filovirus family, a filamentous type virus. It causes hemorrhagic fever. The incubation period is 5 to 10 days. It can range from 2 to 19 days. We sort of use 21 days as sort of the outward limit of how long the incubation period would last. The typical signs and symptoms are fevers, myalgias, headache, rash, CNS symptoms, and bleeding or hemorrhages. The mortality varies depending on the subtype. Commonly what we hear is with the subtype Sudan, it's about 50%, and that it's higher for subtype Zaire. This is a phylogenetic tree of the filoviruses. Marburg virus is a somewhat similar virus that was first identified in Marburg, Germany, back in the late 60s, 1967. It was imported from monkeys, and the outbreak occurred among laboratory workers in Marburg. We're going to be talking about Ebola, which is the two large subtypes are subtype Zaire and subtype Sudan. This is the Gulu Uganda 2000 subtype. Okay. So just quickly about the Ebola outbreak in West Africa. Right now, it's the largest Ebola outbreak in history, and it's the first one in West Africa. As John mentioned, these numbers change every day, but as of August 28th, there had been 3,062 identified cases and 1,552 deaths. Most of the cases have been identified in Liberia and Sierra Leone. There have also been cases, actually the first case I believe was in Guinea, and then there was someone who had traveled from Liberia to Lagos, and there was a cluster of cases in Nigeria, which I think we'll hear about. This map and the table show the outbreaks of Ebola that we are aware of. The first outbreak that was recognized was in what was then Zaire, now the Democratic Republic of Congo, in a town called Yambuku. It was the case that is thought to have been the first case was a schoolmaster of a small village in Yambuku, which is next to a river called the Ebola River, and that's where Ebola got its name. At about the same time, there was an outbreak in Sudan, and these were two different subtypes, so there were two separate outbreaks, but they caused quite a few deaths, actually. Then there were a series of sort of small outbreaks that were recognized until the outbreak in Kikwit, Zaire. And that was a large outbreak, a large response by WHO and CDC. And then the next large outbreak was the outbreak in northern Uganda in Gulu. this was the largest outbreak of Ebola until this most recent outbreak, and it's the one that we worked on and the one I'm going to talk about. Okay, so this is a map of Uganda. Gulu is up in northern Uganda, which back in the late 1990s, early 2000, there was a rebel army up there, the Lord's Resistance Army, a fundamentalist Christian group that was causing a lot of instability, kidnapping children. There was a lot of issues with that. So in the midst of that, there was an outbreak of what was initially thought to be a respiratory illness. And the director of one of the main hospitals in Gulu, St. Mary's, was a northern Ugandan doctor, Matthew Lukwiwa. He had trained in Kampala and in Liverpool, had come back, been working in Gulu for about 10 years. And at the moment, was down in Kampala actually finishing up an MPH in public health. We got a call from the hospital staff saying that there had been a couple nursing students who had died of a respiratory illness. And it didn't sound right, so he went back to Gulu. And within a day of interviewing patients, talking to the staff, he recognized that there was something going on that wasn't normal. And he started thinking it was a hemorrhagic fever and possibly Ebola. So he really alerted local officials, government officials in Kampala, as well as CDC and WHO, and said, I think there's something going on. And it was an example of a healthcare worker on site, recognizing something that's just not, is a little bit unusual, and that something needs to be looked at more carefully. And he really did help get the investigation started early. What could have been a much larger outbreak was brought under control. So based on Dr. Matthews' work, an outbreak investigation was launched. As with all outbreak investigations, the goals were to identify and confirm cases, to isolate and care for infected patients, to identify the contacts and stop the chains of transmission. The plan there was to monitor contacts for 21 days. If at 21 days there were no fevers or symptoms, we knew they had gone the furthest the incubation period could be and that they were safe, and to bring the outbreak to an end. So an important part of outbreak investigations is the definitions that you come up with. These were the definitions that we came up with during the first few weeks of the outbreak. We used the term alert, and this was used by community members to let them know when to alert healthcare professionals that there was something amiss. And that included anybody with the sudden onset of a high fever, sudden death, or hemorrhage. The suspect definition was used by mobile teams to decide whether to transport a person to an isolation ward. And this was anyone with a fever who had had contact with a potential case, anyone with unexplained bleeding, anyone with a fever plus 3 other symptoms. And there was a group of symptoms that we used: headache, vomiting, nausea, vomiting, diarrhea, body pains, myalgias or joint pains. And then probable case was a person who met the suspect criteria who had been evaluated by a physician. Presumptive definition was a suspect or probable case plus bleeding or fever plus 3 unexplained symptoms. Presumptive is what I'm going to show in the next slides, presumptive cases. And then lab confirmed cases were probable cases that had serologic confirmation of Ebola. So, one thing we recognized from the outbreak investigation was that our definitions could have been clearer and simpler. But as often happens in these investigations, you're sort of developing your definitions as you go and you're refining them as you go forward. So that's, and you also have to work with what you have at the site. We were working in a rural setting with a lot of community volunteers helping us with the investigation. So we were using a lot of symptoms and signs in our definitions. Laboratory confirmation we could only do at our hospital settings. Okay, so this slide shows the epidemic curve of the Ebola outbreak in Gulu. So the bars, the green represents the presumptive cases. These were cases that had signs and symptoms but did not have laboratory confirmation. The red bars represent people who had laboratory confirmed Ebola. And you can see that the outbreak started sort of August, September of 2000, and then cases began to increase September, October into late October. And then this is the point where finally what's thought to be about 50% mortality for Ebola Sudan. We found that transmission occurred at funerals, among families, and also in healthcare workers. It was very sad at St. Mary's Hospital, which was the major hospital receiving patients. 14 of 22 staff became infected with Ebola. And this is despite a fair amount of infection control work at the hospital. Among the signs and symptoms of, this is at Gulu Hospital, another hospital in Gulu, sort of a public hospital in Gulu, where there were 62 confirmed cases. Signs and symptoms, the most common symptoms: diarrhea, asthenia or weakness, headache, vomiting, and then abdominal pain. So about 55% of the patients were presenting actually with abdominal pain, and then 20% had bleeding or hemorrhages. Just want to mention Dr. Matthew. He was really a public health hero. When he came back to St. Mary's Hospital, symptomatic treatment, intravenous fluids, maintaining electrolytes, oxygenation, maintaining hematologic support is needed, and treating other infections. There's been some talk of ZMapp. ZMapp's a combination of 3 different monoclonal antibodies to glycoproteins of Ebola. Hasn't been evaluated in phase 3 safety or efficacy trials among humans, so we don't yet know if it really makes a difference. There are a couple of vaccines that look promising. There's the recombinant vesicular stomatitis vaccine, VSV vaccine, that has glycoproteins from the Zaire and Sudan strains of Ebola. It's been tested in mice as well as in monkeys. This vector actually has some advantages in that pre-existing immunity among humans to VSV is pretty low, so it should be something we would respond to. And it's a replication competent vector, which means it reproduces in your body, so we should be able to mount a pretty good cellular and humoral response to it, so a good immune response. There have been some studies in monkeys, and a single dose has elicited strong antibody and cellular responses. These are small studies, but it did protect 4 out of 4 monkeys. And interestingly, they did a post-exposure assay where they injected the monkeys with Ebola and then provided the vaccine, and it protected 4 of 8 to the Zaire strain and 4 of 4 to the Sudan strain. So it's sort of like the rabies vaccine where you can actually inject it after exposure. So it hasn't been trialed. I think there have been phase 1 trials in humans, so it does appear to have some safety and maybe some immunologic markers. There's talk of trying to get this vaccine, and maybe there's another vaccine, which is an adenovirus vaccine, that has also showed promise in monkeys. And there is some discussion about whether trials could be ramped up very quickly. NIH has said, in the United States, has said they would like to do that. Whether they could be launched in West Africa in the current outbreak, that would be something very interesting, but a real challenge to do. And then hospital infection control is critically important. In field settings in Africa, it means proper sterilization of injection equipment, protection from body fluids and skin contact when dealing with patients, but also when preparing dead bodies, and routine barrier nursing. In more sophisticated tertiary care hospitals, a strict isolation, barrier nursing, and universal precautions. I think hopefully we'll hear more, but there's a lot more of hospital infection control that can be done. So for outbreak and in this investigation, this is my last slide. The goal is to identify and confirm cases, and this is what the teams.
Okay. Well, it's critical when you want to design your own infection control plans. The virus, as Dr. Mike said, is a filovirus. It begins in animals, and it can also infect humans. there is evidence of human-to-human infection and as it occurs with an outbreak. Originally, it was discovered in 1976 in Zaire, and this is all review from Dr. Mike's presentation. So the first question then that most people have is, where does Ebola come from? Well, we don't really know, to be honest with you, but we think it's probably from bats. And this is a picture here on the left, and I'll highlight the disease transmission as we go through, but probably comes from bats somewhere in Africa, as far as we know. Now, what happens is that bats may infect other animals, either directly or through things like partially eaten fruit. And that can drop to the ground and another animal can pick it up and eat it. This can cause a cycle of infection. And then these other animals or the bat can infect human beings. Now, when a human being becomes in close proximity to either an animal, it can be through eating bushmeat. Bushmeat is meat from one of these types of animals that lives wild in the jungle. It can also be from picking up some fruit that was partially eaten by a bat. When any of these things happen, if there's virus on that piece of food, that can cause a human infection. Then, once there's a human infection, that can be transmitted from human to human. Okay, human to human transmission. This is what we're all concerned about. How is Ebola transmitted? Okay, Ebola is transmitted through touching body fluids of a person who is sick or who has died from Ebola. Okay? What does that mean? That means what are body fluids? It can be anything. That means it can be saliva, it can be urine, it can be diarrhea, it can be secretions it can be vaginal secretions or even semen, and importantly, it can be sweat. So there is virus in sweat, and sweat is on the skin. Okay? You don't get Ebola from touching the skin, you get it from touching the sweat that's on the skin. Okay? That's important. You can also get Ebola by touching or using objects that's contaminated with Ebola. So for example, if a case patient with Ebola has diarrhea on the floor, for example, or vomits on the floor, and somehow someone else healthy touches that or is in contact with that, then they can get Ebola. But the next question is, how does the person get Ebola? If you're healthy and you touch a contact with Ebola, does the Ebola go through your skin and infect you? No. That's not how you get Ebola, okay? It comes when you touch your face or touch a mucous membrane. That's how the virus enters your body. What does that mean? That means that hand hygiene is the most important thing. I'm going to talk about this in a little bit. So, facts about Ebola. You cannot get Ebola through the air. This is not an airborne disease, okay? That means it's not like measles or even other diseases that are airborne. Tuberculosis, for example. It's droplet and contact. That's how you get Ebola. You can't get Ebola through the water. The water system is safe. You can't get Ebola through food, unless, of course, it's bushmeat. So, because we know that it's spread through contact, there are a number of infection control precautions that are necessary. First, standard precautions. These are things that all hospitals must prepare and do. But hand hygiene, as I mentioned, is the single most critical step because healthcare workers or anyone will have Ebola on their hands. And what we know about is that oftentimes healthcare workers will touch their face by accident without even knowing. I'm looking around the room, I see probably half of you are touching your face right now. You probably don't even recognize that you're touching your face. That is a high-risk behavior for Ebola. That's why hand hygiene is the single most critical step. We see all these pictures about PPE, head to toe, covered with Tyvek or plastic and all these things. And that's important, and I'm going to talk about that too. But again, the single most important thing is good hand hygiene. With soap and water is fine. Alcohol-based hand rub is even better. Okay, droplet precautions and contact precautions. Why? Because again, the virus is in your secretions. droplet precautions are important. When you cough, if you have virus in your secretions, in your saliva, you'll cough. Again, what is droplet precaution? It means basically less than 2 meters, right? So droplet precautions, things like having a mask, a surgical mask, having eye protection, goggles. And as a result, the PPE that's needed when you're dealing with suspected or confirmed cases, you must have a gown, gloves, and a mask. Respirator can be used, but a surgical mask is fine. Remember, this is not an airborne disease. Sometimes people like to use respirators because it's more secure, it fits better, that's fine. Also, a face shield, full-length face shield is very helpful because one of the problems actually with the PPE when you use goggles is that it becomes very hot and becomes very uncomfortable and becomes itchy, you know? So what happens when a healthcare worker is working, they're tired, they become itchy, what do? They scratch their face. All of a sudden, they have virus potentially on their face. That's why we often recommend a full-length face shield. Also, head covers can be helpful, as well, and also shoe covers. When are they helpful? It's helpful when you think there might be exposure to body fluids. If your patient is having, you know they're having vomiting and diarrhea, then you should go in understanding that you might be exposed to fluids and you should take the precautions necessary, including shoe covers. Because if you think about it, if you're going into a patient's room, they're having active vomiting, there might be vomit on the floor. Where is the virus going to be? On the floor, then on your shoes. So these are common sense things you need to think about. Okay, Dr. Mike covered this already, but what are the signs of Ebola? Generally, signs will happen 2 to 21 days after contact with a person who is sick from Ebola. So the incubation period is 2 to 21 days. Most commonly 1 to 2 weeks. And importantly, and this is generally thought to be true, people who do not have signs of disease cannot spread the disease. So that means if you've had contact, exposure to a patient with Ebola, you do not need to be quarantined, okay? Now, there are exceptions to this, and there are some extraordinary public health measures that people have taken. But nonetheless, simple exposure does not mean that you'll get the disease. And in fact, if you look at case series of attack rates for people who have known exposure to contacts, the attack rate is only, what would you think the attack rate would be? You know, in the media you think that the attack rate would be 90%, you know, 80%. This is among unprotected exposure. But in fact, among unprotected exposure, the attack rate is only about 25%. So we have this conception that Ebola is a terribly contagious disease, and you just walk near someone with Ebola, and all of a sudden you'll get the disease. That's not true, okay? Again, this is among family members who are taking care of patients with Ebola. The attack rate was only 25%, okay? This is without any PPE. What are the signs of Ebola? In general, fever, headache, chills, weakness, tiredness, very similar to other diseases. And then gastrointestinal symptoms are very common, including vomiting, diarrhea, and abdominal pain. Some other kind of strange symptoms are sore throat and hiccups. So what does this mean? This means, other signs of Ebola virus disease, redness in the whites of the eyes and a rash, and also bleeding in about 45% of cases, including nosebleed epistaxis, also easy bruising, and severe bleeding can lead to gastrointestinal hemorrhage and shock. But what does this mean? All these symptoms are very similar to many other tropical diseases that you see every day. Malaria, typhoid fever, cholera even sometimes without fever, other hemorrhagic fevers. These are very similar to Ebola. And most people who are sick with fever, vomiting, and diarrhea do not have Ebola. It's very important to remember. We're very concerned about Ebola, but we must remember that there are patients that are presenting for care that are sick that need attention. And most of these people will not have Ebola. Okay, now I'm going to talk about the outbreak in Nigeria. This outbreak is important for your perspective for one simple reason. The outbreak in Nigeria, and I'm going to go through this outbreak in more detail, but this outbreak was due to one person who was in Sierra Leone and he had Ebola, and he traveled to Lagos. Now Lagos is the largest city in Africa, okay? 20 million people in Lagos. And what does that mean? That means that this was an imported case of Ebola. If Ebola comes to Thailand, where do you think it's going to come? It's not going to come in the jungle, right? It's going to come by air into Bangkok or another major city. So that's why this is an important lesson for you to learn about. Okay, again, Nigeria has a total population of 174 million. It is the most populous country in Africa. Lagos, which is here in the circle, in the southwestern corner of Nigeria, population of 20 million people. It's the largest city in Nigeria and the largest city in Africa. It is one of the most densely populated cities on the planet, with 51,000 people per square mile. And it's a port city, meaning that there is a lot of traffic in and out of the ports from the ocean. Okay, let's talk about the index case. On July 20th, 2014, a 40-year-old Liberian American came into Lagos from Liberia. He actually had connecting flights through Ghana and Togo. He took a plane from Liberia to Ghana to Togo to Nigeria. Now this gentleman was visibly sick on the plane. He had
coronavirus or MERS-CoV. Before I start, I would like to give a brief background of myself. So my name is Dr. Nora Cheer. I come from Cambodia, which is next door to you. And I did my medical training in Cambodia and then worked in a children's hospital there for a couple of years and joined WHO in 2008 and then just moved to CDC as an epidemic intelligence service officer last year. I'm not a real expert on MERS-CoV, but since I got positive strain RNA virus, and the first coronavirus was isolated during the 1960s, and to date we know of 6 human coronavirus, and 2 of them I think most of you are familiar with or have heard many times, which include the SARS coronavirus, which hit the world in 2003, 2004, and the most recent one is the Middle East Respiratory Syndrome coronavirus, or MERS-CoV. I'm going to talk about the first reported case of MERS-CoV. He was the 60-year-old man presented on June 13, 2012 with 7 days history of fever, cough, and recent shortness of breath in Saudi Arabia. The patient developed acute respiratory distress syndrome and multi-organ dysfunction syndrome and then died on June 24. Luckily, no close contacts with severe illness were reported. The second case was in a 49-year-old Qataris national with the onset of illness on September 3rd with mild respiratory symptoms. And on September 9, he was admitted to a Qatar hospital. There are 837 laboratory confirmed cases so far, with 35% case fatality rate. And the most recent onset was June 4th, 2014. And the majority of cases, of confirmed cases, are male. The median age is 48 years and range from 0 to 94 years. And all cases have epidemiological link to 9 countries, to Saudi Arabia, Qatar, United Arab Emirates, Jordan, Yemen, Oman, Lebanon, Iran, and Kuwait. So this graph shows the number of cases that were imported from the Kingdom of Saudi Arabia. As you can see, most of the imported cases so far are from the Kingdom of Saudi Arabia. For transmissions, person-to-person transmissions have been well documented, and so far we have 29 clusters reported. Some are household, and most of them are in healthcare settings. The median incubation period is about 5 days, range from 2 to 14 days, and the route of transmissions is unknown. We don't know if it is transmitted through direct contacts, through contacts, or through droplet, or through airborne. Luckily, there is no evidence of sustained community transmission. So here is the interim infection prevention and control guidelines for hospitalized patients. If you have a hospitalized patient in your hospital, you need to implement all 3 additional transmissions-based precautions, which include contact, the natural histories of the illness. So we collect NP, nasopharyngeal, oropharyngeal, urine, serum, and stool every 2 days, and we send the specimens to the State Health Department lab and to CDC lab to do the RT-PCR, and we also tested the asymptomatic contacts and symptomatic contacts. I'll talk about the asymptomatic contacts. We collected the sera twice. The first sera were collected during the investigations, which were 2 or 3 days after their last exposures, and we collected their sera again, the convalescent sera for MERS-CoV antibody, and we collected 12 to 14 days after the last exposures. The recommended durations is 14 days after their last exposures, but because some of the healthcare workers had to go on vacation, so we kind of compromised and collected the specimens 2 days before the recommended date. For symptomatic contacts, we collected nasopharyngeal and oral, and we sent the specimens to the state lab and the CDC lab for RT-PCR, and we also collected convalescent sera on between day 12 to day 14 after their last exposures. It is important to note here that it is 12 days after the last exposures, because sometimes you put it 12 to 14 days, but you don't know which was the first day. So it's important to know that the day 1 should be the day of last exposures, not the day that the healthcare workers were first exposed to the patients. It's important. So as a result, we identified 53 healthcare personnel's contacts. We interviewed 48, and 3 were considered as not exposed after the interview. The hospital gave us the list, we talked to them, and then we found out that they were actually were under full PPE, so they were excluded from the list. And